whilst we wait for people to think of questions and anything else, I'm going to put a comment to all of you, which is when you talk about AKI, and we're looking at scoring systems such as KDIGO, we group them into periods. So you've got whether it's 0, 1, 2, and 3 as how we measure renal dysfunction. But really, it's actually a continuous scale because we don't just fit into a small subsection of those. So how do you think that really influences how we look at the results? Because obviously when you're doing the statistical tests, you're trying to divide those things up. You're using tests that are looking predominantly at an interval, whereas actually if it's a sliding scale, how can we really understand that? And especially with the ideas of biomarkers, how can we sort of get that into our heads?
Everybody votes for me to answer first. AKI is a continuum, and it does exist on a spectrum where injury will continue to progress if there is no intervention done. And the new 2020 criteria dropped the division of patients into stages 1, 2, and 3, recognizing that is that the pathophysiology is on a continuum process. But I think that the role of biomarkers and us looking at those lab results sooner, like with your post-protamine blood sample, for example, or even on bypass while we're running extracorporeal circulation, would help us understand when kidney injury is occurring or when we're at risk and prevent it from progressing further. I think that would be a very important role of them. For example, we monitor continuous blood gases. So why couldn't we continuously monitor our renal perfusion or renal function with a biomarker?
I have a follow-up question to that, which is if you had that data and you knew ongoing that you were somehow causing some AKI, what interventions would you do to stop it? I think that's the, right? Oh, well, mine's in the pediatric population. She said the ones that I presented. But, I think that's sort of the million-dollar question is, throughout my career, whenever I would see the urine have some hemolysis in it, I thought, well, this has got to be indicative of AKI happening. And that's not what we find in our long-term patients. We have patients that are on bypass for 20 to 24 hours sometimes, and they don't end up with any AKI afterwards. So there's something going on. I'm with you. I want to know exactly when, where, and how. Dr. Tabby?
Actually, I agree. In my point, I think the two important things, maybe I'm wrong, but just sharing to everyone. The first one is biomarker. You need to careful and specific which one for, because the biomarker have the peak. Even we keep continue monitor. Let's say since start the CPB, you may not see anything because it have the peak. Some biomarker the peak after. Well, that's a question. When we said after CPB, it depends on the time. I mean, sometimes it's peak at 6 hours after CPB. In my opinion, I mean, the first one is biomarker. You need to know exactly when the peak of biomarker. And next thing, I'm thinking about the oxygenation. One that we need to really understand is that oxygen tension in kidney is different from the other organ. Kidney is very good for do the renal auto-regulation that I'm showing you. they are very good for sensitive for pressure, but they are not good for hypoxia, hypoxic condition. In medulla, in the inner medulla, oxygen tension just only 10 millimeter mercury, which is risky to risky for the kidney injury by themselves, even normal physiology. So let I summarize my answer. I think for two things. The first thing, you need to clarify for biomarker and when the peak of biomarker, and the last one for the important is oxygenation of the kidney, and we need to know for the basic physiology. They are risky to hypoxia by itself for the kidney. And I appreciate for, even we know the injury and how we protect it, how we prevent it. Still on my question. Yeah.
I just keep asking questions to these two brilliant ladies. That makes me think, I wonder what the optimal PO2 would be on bypass for regulating AKI and for what's happening in the kidneys. I want you to do that next.
For now, I still agree with Dr. Lucile. I mean, for the DO2I that we keep about 300. I still a big fan for that idea and for the data. But yes, of course, we need more and more for the research and unveil the question. But that's my answer for now.
Richard Melchior, Children's Hospital of Philadelphia. To all three speakers, you guys did a great job. Jen, you can't see me. I'm sorry. I'm behind the podium there. Hi. Actually, great talks to all of you. I'm actually going to just centralize a little bit with Tristan. I have a couple questions. One, are you making any certain modifications for this patient population for these challenging heart transplant patients, say 10, 11, 12 kilos? Are you bumping up the size of your boot, your venous line, your oxygenator? When you're in between sides, you're just like, forget that, I'm going higher, because you have to hit that 3A plus index?
Yes, definitely. So we do that kind of by nature at our institution anyway, because we do have those long pump runs. And so one of the things we've realized over many years of failing and trying is that we need more surface area for long pump runs. Yeah. And to support that extra flow that happens when you have all of that return. So yes, that's a great question, and we do that. Thank you.
All right. Second one is, it's the phantom venous pressure that nobody really knows about, and that's the IVC pressure, right? With this study, I didn't see that. Did you measure the parameter of the IVC pressure at all?
So intraoperatively, we didn't.
Okay.
It's near impossible to do that when you have SVC, IVC drainage. We sometimes have an RA line, but you're cutting out the heart. Mm-hmm. So we don't monitor it separately or place it in. But they did post-operatively. And that was one of the biggest tip-offs in the ICU, is that they were having some venous congestion, and lo and behold, all those patients ended up with AKI.
So in the past year and a half, we're starting to put femoral venous pressure lines in.
Oh, awesome.
Yeah, especially in the single ventricles.
Yes,
so
great.
During bypass, we're knowing that phantom pressure now.
And what are you doing about it?
What are we doing about it? Optimizing, right? Increasing your vacuum and trying to find that 3.6 to 4.0 index if you need to flow that much, or maybe you put a little more pressure on board to then bring the flow down, to bring the pressure down. It's a little bit of this and that, and to optimize it.
Yeah.
But we're looking at that pressure now when we're doing these challenging cases, especially when you have to flow that much. Mm-hmm. So you worry about that venous congestion and AKI buildup.
Yeah. Great. Thanks.
Any other questions? Okay.
People are into AKI.
Well, I suppose the comment to that would be really that if you look at mortality rates across cardiac surgery, they've plummeted. Touch wood, people don't generally die from heart surgery anymore. And it's now trying to reduce the morbidity, which is still very, very high. And AKI is the kind of critical one, because obviously that's the one where you can develop more longer term problems from your chronic in time kidney injury as well. So it's got a knock-on effect that will go on for many, many years. So hence the reason why everybody's now trying to reduce that down, because that has massive effects, not on in terms of the economics of looking after these patients. They stay in hospital a lot longer, so you can't treat the same number of patients because they bed block. So for the sort of next few years, unless we can solve it, that is going to be sort of the main focus, is purely just to get that logistical question.
Okay, a consensus from the online chat. Several questions came up. For Dr. Tabby, has the duration of bypass been a part of your study, and how did those results affect your data?
You repeat the question again, please.
Yeah, did you study the duration of bypass, and how did that affect your data? Long pump runs versus short pump runs?
Actually, I did not study compare for the time. But let me answer the question by literature review. Yes, of course, absolutely. I would say from based on my review, the longer the duration is a higher risk for all complications. Yes, of course. But let me share with you with two things. Inflammatory response is increased, go up and up. It depends on how long your duration is happening. For the time, when we're talking about the time, when we're talking about the CPB, we need to separate with two things: the CPB camp time and the whole CPB time. The camp time is very, very important because it's immediate ischemia reperfusion injury. And it's not affect just only for the heart. I'm wrong. When I was young, was a perfusionist, I just thinking when you release the cam and ischemia reperfusion injury is happening for the heart, but it's not true because the inflammatory response is affect all the organ. The longer cam time, the higher risk for all morbidity. That's the most important for me. And yes, of course, for the longer CPB, along with the camp time, but camp time is very, very important. Yes.
My next question is for Tristan. People would like to know what charting program you're using to track all of your variables, and have you started setting targets for interventions?
So we use Connect to chart on our pumps, but for pulling our data, we had to do everything by hand. So I was going through every single chart for every single patient and pulling that data out separately and creating my own spreadsheet. We're moving to Epic, and I'm hearing from my Canadian colleagues in the corner that it's difficult to pull data out from that, but that they're working on that too. So we're hoping, we wish we had a more consistent a way to track that data, but we haven't had that so far.
Okay. And for Jennifer, did you use a hemoconcentrator during bypass for this study? And if you did or didn't, how did that affect your results?
Wasn't significant.
Okay, thank you.
What was significant, and I'll present on Friday, also on AKI, but slightly different topic, is fluid balance. And so we found that patients with a higher post-pump and ICU fluid balance and the effects of hemodilution are significant for AKI. Spoiler alert.
Hi, I'm Anna Maria from Sick Kids in Toronto. Question for you, Tristan, regarding your transplant patients and the MAPS that you were targeting of 65. Are you altering that for the neonatal population, and what kind of targets are you looking at based on patient size, considering that we're dealing with a wide range here?
Yeah, that was something that was really enlightening for me, because we usually target MAPS based on neonatal population, size, age. And for this, we didn't have very many neonatal transplants, to be honest with you. We do have a handful of them every couple of years, but they end up on VADs and they grow with them. So they're not exactly neonates, but we did that for everybody. And that's what made the difference. So it was unusual, and it was also a little bit uncomfortable to push the MAPS up on those patients. And I wasn't sure how to do it. It doesn't feel right to keep bolusing neo into a 3-month-old, but that's what we did, and it showed lower rates. Great question.
Okay, great. Thank you.
Yeah, thanks.
Hi, thank you for 3 excellent talks. I have a hypothetical question for all 3 of you. There's some people in this room who are very brilliant and into research, and some of them even run registries. So if you had unlimited budget, what would be your, like, what would you like to ask them to do research in? Like, for example, Tabby, you're looking at differences between men and women and the age, and for Engel and for pediatric perfusion in transplants, what would be your #1 research project?
Why are you looking at me?
I want to hear you first.
Okay. Well, I think it's kind of a hybrid of everything that we've been talking about, because I really would like some sort of point of care testing to show that. But if I have that availability and that data, I want to know what to do with it. So if I'm showing that I'm having AKI early, what's my strategy that I would change? So I really like Chop and Rich's idea of measuring sort of those femoral pressures. But again, I'm not sure that I have the capability. You're in that, chicken and egg situation where you have to flow high in order to provide cardiac output, but then you're flowing too high and then you're hurting the kidney. So I wish I had the ability to pull all of those data. I really like NIRS. I'm still at an institution where when the NIRS plummet, people are like, oh, don't worry about it, it's not reliable. And I'm like, well, actually, it is, and here's what we look like, and then we had this thing happen and now they look like this. So I wish I could pull as much data as I could in terms of flow, pressure, hematocrit, all the variables that we looked at, and then some would be something I'd like. Jennifer? Oh, you have one. Sorry, you don't.
I don't know if I mentioned, but Engel is actually bound to matrix metalloproteinase 9, which is released in ischemia reperfusion. And here's another spoiler alert, come to my talk on Friday. There are a type of antibiotic that inhibit matrix metalloproteinases, specifically 9. Doxycycline is one. And is anybody here from Alberta? Alberta in the room? Anyone? No? Oh. They registered a trial some years ago of seeing if giving patients doxycycline preoperatively before bypass was going to impact their rates of AKI. But I haven't been able to see or talk to anybody about what the results are yet, so it's yet unpublished. So I'm wondering if we could have a registry that looks at biomarkers and various interventions to create the data that you want and that other people want and that I want.
For me, I was thinking, one, we need to understand there are multifactorial effects for the kidney. If for me, if we focus on hemodilution, we look at the hematocrit, we have the data for hematocrit, but you will have the effects from multifactorial factor affect the kidney. For example, inflammatory response, which is so many cytokine will affect. If you collect the data, hematocrit, let's say DO2I, everything about the hemodilution, we also have the inflammatory response. If you collect the hemodilution, inflammatory response, you still have ischemia, reperfusion, injury effects on of those. So many parameters. But for me, which one is the most and the more impact based on my knowledge on basic physiology that I have? Kidney is risky to hypoxia by itself. Hemodilution factor, DO2I, hematocrit, which is I'm big fan for those parameters. And also we need to really understand for the ischemia reperfusion injury, which is the effects after is our CPP. That's the parameter we also need to have. And also for the biomarker, but but I'll mention again, we need to clarify for the peak of biomarker. When it's peak, what that is mean, we need to show and understand that. That's from my point of view.
Thank you.
Excellent conversation. Appreciate all three of your talks. This question is for Jennifer. My name's Jerry Hillshorst. I'm from the Indiana University. Hello. Are you familiar with the NephroCheck? It is a point-of-care test that measures the biomarkers TIMP2 and IGFBP7. And have you all used that at your institution?
No, I'm not familiar with it, and I'm going to look it up, so thank you for bringing it up.
You're welcome. We've been using it at our institution, both preoperatively and postoperatively, as a predictor of the probability of our patients developing AKI, and then postoperatively to detect it early and modify our postoperative treatments. And it's called NephroCheck. Thank you.
Wait, I have a question about your NephroCheck. So it's a urine, right? NephroCheck's urine based? Right?
Is it your, yes.
I think it's urine based. Yeah. Okay. That's great. Yeah. I know some people have been using it, but weren't sure again, what interventions to take when they see it happen. So
we've been studying AKI at our institution for about 5 years now. And it's been a combination of high flow, high crit, using the CDI 550 for delivery of oxygen. I believe Dr. Nargaliji published a very good report several years ago about flowing at 280 milligrams of oxygen per minute per meter squared. So we're indexing, our cardiac index and delivery to the body surface, ideal body surface area. And we have seen a significant amount of reduction in our AKI rates. So it's been kind of a combination of all of those modalities.
yeah, I find that interesting because that's what we found in the peds population, and that's what you're finding in the adult population as well. It's interesting.
Thank you.
Thanks.
We just had one question online there. They just asked about whether or not washing packed red blood cells reduces the incidence of AKI prior to transfusion.
Does anyone know we use a lot of wash blood at my institution. That's a great question. Does anybody know if washing reduced any AKI? You probably use packed cells.
The results that I was reporting was all packed cells from the blood bank that were unwashed because it's adults. Subsequently, after doing this research, I transitioned into pediatric practice and did start washing cells. And I would highly recommend it because I do think that there's a contribution to the immune system activation that's going along with transfusion of products. And it's also why I was asking if anybody's using single donor plasma. Anyone? For transfusion, because that's another thing that I would like to look at, is the impact of washed red cells and single donor transfusion on AKI because of the immune system response. Yes.
Just in the interest of time, we're going to have one more question, then we'll wrap up, because I think otherwise we'd be here for days just on this topic alone. So thank you, guys. Jim?
Jim Rager, Cincinnati Children's. Thank you, ladies. Some outstanding presentations, of course. Tristan, this is now the second talk that I've heard you give where you have not correlated length of your bypass runs with poor outcomes, absolutely destroying my argument to our surgeons for being faster. So, but clearly you guys are doing something right. So thank you for sharing your experience. I'm sure a lot of us in the room, and myself included, were taught no urine on bypass, you're doing a bad job. Nowadays, we have all these amazing biomarkers. Our science has gotten better. Our understanding has gotten better. But for old rednecks like me who like to simplify things, have you correlated any of your findings with urine output on bypass or seen anything like that?
It wasn't significant for my group.
So I've been trying to get buy-in because we have a very stable population where the same surgeon does the same cases, and sometimes we have too much urine, and sometimes we have no urine, and sometimes the urine is very red, and sometimes it looks fine. And so I've been asking, I said, hey, when we have this much hematuria, can we take a look at this and correlate it with AKI? But that patient population doesn't really exhibit AKI regardless of any of those factors. So nobody wants to buy in to do that part of it. But I'm with you, Jim, like it's hard to know. Same thing, if we're not making any urine, everyone gets really nervous, but then sometimes post-operatively, we don't have any problems. It's a confusing topic for sure. Tabby? Thoughts? I want to say something. I think Tabby's really onto something with cross-clamping because, Jim's citing this data that we looked at these super long pump runs and they didn't have adverse outcomes, but they had really short cross-clamp times. So I think there's definitely something to ischemia somewhere in the body presenting a problem everywhere in the body.
Actually, I have no additional, but I have one experiment for measure the urine. Just sharing. We have three researchers. Two of them measure the urine. They inject the G1, activate the G1 in the kidney in female. They got the same result. The volume the same result, which is a 5 millimeter, 5 microliter per min in rat study. I did the same, everything the same. I got 10-fold of them, for the urine collection when I activate the G1. It may not the answer related for the CPV, but I just I'm sharing with you. Urine is kind of very different. Maybe we cannot, we nervous when no urine, when we control the CPV, we kind of no urine, we kind of know what, but nothing happened. But sometimes high urine also nothing happened. Urine is very fluctuation parameter in my point of view for now. And yes, I'm still curious and thinking about the ischemia reperfusion injury is affects for the kidney, which also that's my point for now.
Thank you.
Okay, I think we'll wrap that up there. Thank you so much to all of you. It's been a fantastic discussion session. I'm sure we've all got now questions we're going to come and ask you, so prepare for that. We're going to finish this session. We'll come back at 11, so go and grab a coffee. But just again, thank you so much for an excellent presentation discussion.